Dear colleagues, it's an honor and a great pleasure to participate at this year's Lung Symposium and to share with you some thoughts on what I believe is one of the major unsolved issues in acquired heart disease. Extracardiac implications of heart diseases are known for quite a long time, and the first descriptions date back into the mid of the 19th century. Interestingly, these first analyses very much focused on venous congestion and one particular organ, which is the liver. Sheila Sherlock, a hepatologist working in the mid of the 20th century in London, is credited with the first systematic approach of what she later defined as congestive hepatopathy. She studied liver biopsies and necropsy samples of tissue, of liver tissue from patients with various forms of heart disease at that time, and defined specific histomorphological changes I will highlight later on. One of her major conclusions was that cardiac fibrosis or cirrhosis should be suspected in mitral disease with repeated episodes of heart failure, especially if there's an associated tricuspid valvular incompetence. Nowadays, the spectrum of acquired heart disease has changed significantly, as well as its management. But ironically enough, without having made substantial progress in this field, we are coming back to Sheila Sherlock and many of her colleagues, because in adult cardiology, there's a growing clinical need to understand chronic right heart failure, particularly in the presence of tricuspid regurgitation. This need does not come as a surprise, because we made substantial progress in the treatment of left-sided myocardial and valvular pathologies, either by medical, surgical, or interventional procedures. But as a consequence, we are facing more and more patients presenting with advanced right heart remodeling and impaired right heart function. And a substantial proportion of these patients displays tricuspid regurgitation. Indeed, tricuspid regurgitation acts as a driver of the disease in these patients and sustains a vicious circle with right ventricular right heart remodeling, begetting tricuspid regurgitation, which enhances volume overload, and this again begets right ventricular remodeling. Until recently, there was only one single option for us to treat these patients, and this was symptomatic therapy by diuretics, with all its limitations and all its difficulties in elderly patients with advanced heart failure. Surgery is often not an option in these patients because of relevant comorbidities, severely impaired right heart function, and many other clinical features, putting these patients at increased surgical risk. However, as we will hear later on in more detail, transcatheter approaches emerged, and we now have, for the first time ever, the possibility to offer an additional treatment option to these patients and to treat tricuspid regurgitation in this patient population. But at the same time, we can study acute hemodynamic changes after tricuspid regurgitation repair, with its implications on backward failure, on VA interaction, and forward failure. And this, I think, is a unique, novel opportunity to get further insights in this poorly understood clinical scenario. The same holds true for systemic implications of advanced right heart failure. There are manifold systemic implications, and these implications act on the kidney, the liver, as well as the gut. Indeed, tricuspid regurgitation has to be understood as a systemic disease in these patients, because these patients are suspected or subjected to a massive pulsatile reflux of blood into the venous system, as well as a profound remodeling of the venous system due to massive tricuspid regurgitation. And I would like to briefly summarize the current knowledge on these systemic implications with particular emphasis on cardiorenal, cardiohepatic, and cardiointestinal interactions. In the liver, chronic passive congestion leads to dilatation of the liver sinusoids as well as enlargement of the sinusoidal fenestra as shown here. There's also activation of the liver sinusoidal endothelium as well as the hepatic stellate cells, and this contributes to hepatocyte atrophy, to fibrosis, centrilobular and sinusoidal, and sustains an intrasinusoidal pro-inflammatory and pro-thrombotic response. In contemporary biopsies cohorts of patients with advanced heart failure, there is indeed centrilobular and periportal fibrosis, but liver cirrhosis in these patients, even with advanced stages of heart failure, is rarely observed. Congestive hepatopathy displays a distinctive biochemical profile on laboratory analysis and is associated with an increase in cholestatic liver enzymes, meaning alkaline phosphatase, gamma-GT, and bilirubin. In contrast, the transaminases are rather elevated in a low output situation, such as in acute heart failure or in most extreme forms in cardiogenic shock. We had a more detailed look at the cholestatic enzymes in patients with tricuspid regurgitation-associated heart failure before and after transcatheter therapy, also before and after tricuspid regurgitation repair. And we defined a cardiohepatic syndrome consisting of elevation of 2 of 3 liver enzymes. Such hepatic syndrome was present in nearly half of these patients, and tricuspid valve repair by interventional techniques led to a reduction in bilirubin and alkaline phosphatase as well as gamma-glutamyl transferase. Interestingly, the cardiohepatic syndrome had prognostic implications, meaning that patients with an hepatic syndrome had lower survival than those without the cardiohepatic syndrome, despite similar TR reduction. So the cardiohepatic syndrome turned out to be a profound prognostic implicator in this patient population. The concept of cardiorenal interaction changed significantly over the last years. Traditionally, it was believed that renal hypoperfusion due to a reduction in cardiac output is the primary and probably only driver of renal damage and heart failure, but this complex changed because now we know it's much more complicated. It's not only including a reduced cardiac output with activation of neurohormonal and inflammatory pathways, also increases in central venous pressure and right atrial pressure and cardiac congestion are important contributors to this adverse cardiorenal interaction in heart failure, and finally lead to renal venous hypertension, renal congestion, and loss of renal function over time. Indeed, in patients with heart failure, central venous pressure is the discriminator of worsening renal function, whereas cardiac index is not. In patients undergoing tricuspid repair, in elderly patients with severe right heart failure and symptomatic right heart failure, there is profound renal impairment. So a large proportion of these patients displays an impairment in eGFR. On follow-up, after more than 1 year, there's a further decline in renal function over time. But what's interesting is that if such repair is carried out successfully, as shown in the middle, then there is a reduced likelihood of a cumulative incidence of a combined renal outcome consisting of acute and chronic renal failure, end-stage renal disease, and an eGFR drop of equal or more than 50%. In addition, a successful procedure, successful TR repair in these elderly patients with chronic right heart failure prevents a decline in eGFR over time. So EGFR remains stable in those with a successful tricuspid regurgitation repair, and central venous pressure played an important role in this for this effect. Cardiointestinal interactions are very complex, and astonishingly, they are only studied in patients with left heart disease. So there are almost no data on patients with right heart failure, at least in acquired heart disease and in elderly patients. It's complex, so splanchnic congestion leads to a decrease in the arterial venous pressure gradient and also to a relative ischemia of the bowel wall, favors bowel wall edema, and this begets malabsorption and intestinal permeability, leading to translocation of bacterial products and substances into the bloodstream, such as lipopolysaccharide. This is likely responsible for the fact that in patients with very advanced stages of chronic right heart failure with associated TR, there is a large proportion of patients which is either at risk for malnutrition or malnourished. And after repair, coming back to the interventional repair techniques, there is actually a beneficial effect on the nutritional status in these patients, and patients with an improvement in nutritional status indeed face a better outcome than those patients who do not. And an improvement in such nutritional status, as observed by an M&A questionnaire, is also associated with better liver function, as assessed by cholinesterase, and also higher protein levels and albumin levels. So the question is, these are rather descriptive data of organ function before and after a novel intervention, but the question is, of course, do we have any mechanisms behind it? And our group focused very much, or came from a hemodynamic point of view, and had a look at the at cardiac indices in these patients with severe tricuspid regurgitation-associated right heart failure, and almost 30% of these patients had a high cardiac output, so a cardiac index of more than 2.6, and most interestingly, these patients with a high cardiac index faced the worst outcome. And what was also interesting to see is that despite a reduction in tricuspid regurgitation, as depicted here with the regurgitant volume change, the right atrial pressure remained the same. Furthermore, these patients with a high cardiac index displayed lower systemic vascular resistance, and that's why we defined such phenotype of TR-associated right heart failure as a hypercirculatory phenotype. This was also associated with more hepatic congestion, so gamma-glutamyl transferase and alkaline phosphatase were higher in this patient, liver synthesis was lower, and there was a higher percentage of ascites in these patients. So the question is, what's the mechanisms? What's mediating such a hypercirculatory phenotype? Of course, there could be several explanations. One could be the liver. So changes in the production of vasoactive substances would be one option. Or, as I said, the complex cardiointestinal interactions with, for example, translocation or intestinal shift. This could well be because what could be a potential mechanism underlying hypercirculation. Well, it could be a chronic systemic inflammatory state, and this could well be due to a change in the intestinal milieu as depicted here, so a change in microbiota composition or in the microbiome functional diversity, increased translocation, activation of cellular or humoral activity, mediating a inflammatory process which induces vasodilation and at the end underlies this hypercirculatory phenotype. I think we are rather at the beginning of our understanding, but at least this hypercirculatory phenotype is one starting point to get further insights into this poorly understood disease. So taken together, extracardiac implications of TR-associated right heart failure are common, they are prognostically relevant, but largely understudied in contemporary cardiovascular research, and therefore they are poorly understood. In addition, many concepts of venous congestions haven't been tested in patients with right heart failure, but rather in patients with left ventricular impairment. Transcatheter TR offers a novel and safe option to treat and understand tricuspid regurgitation-associated right heart failure. It's important to see if there's a window of opportunity, if there's reversibility in all these systemic implications of TR-associated right heart failure, but also, as I pointed out, to get further mechanistic insights and identify potential drivers of the disease. Hypercirculatory phenotype is a promising first step to study cardiopathic and cardiointestinal interactions. And with this, I would like to thank you for your attention, and I'm looking forward to discussion. Thank you very much.
Thank you, Dr. Besler, for this wonderful talk. Just one question. How did you measure cardiac output in your hypercirculatory patients?
Both by invasive means, so by thermodilution, and yeah, I know, difficult, and also by echocardiography, so L4T diameter multiplied by the VTI.
In TR with cardiac thermodilution, you measure numbers, but you don't measure cardiac output because of tricuspid regurgitation. Gives you false positive, false high cardiac output measurements. You know this. So that's why I'm asking.
Yeah, I mean, that's an ongoing discussion. I mean, of course, there are studies which say that you cannot use thermodilution in these patients. There are other studies that argue the opposite. Of course, I mean, it's a limitation, but we match this with the echocardiographic data and think that this concept is still reliable.
I mean, maybe it sounds a little bit theoretical at the moment, and you said it's a starting point. But when we saw patients with the highest cardiac output, and there might be some confounding with the measurements, but there's still a difference between 4 liter and 1 liter, and you see that the ones with the high cardiac output have the worst outcome. We were really puzzled.
Yes, but the higher the tricuspid regurgitation, the more cardiac output you measure, which is a false measurement by your thermodilution. That's physiology. That's not my idea.
No, I agree, but it was very similar outcome when we measured it with VIC, and when it comes to the measurement of cardiac output according to left ventricular stroke volume, which also has some problems with it, but that should not be confounded by tricuspid regurg. So I have no doubt that in some specific patients you could argue whether that's correct, but the overall concept of high and low cardiac output, I think that is not an error of measurement. Titus?
Yeah, super interesting topic. Thank you very much. When you talk about vasoactive substances, what precisely are you thinking at, and what's the link to cardiac index?
Well, I mean, we have a similar phenotype in chronic liver disease. So patients with liver cirrhosis, at least in advanced stages, also shows some kind of a hypercirculatory dynamics when they're tested, both also by echocardiography and invasive diagnostics. And there are potential candidates, at least they were studied in chronic liver disease, like adenosine, nitric oxide, and a few more. But I think so. I think that this concept is somehow reliable because in the liver disease we see something similar, but of course due to the congestion and the profound alterations we see in liver structure on biopsy, I guess there could be alternative candidates, metabolic candidates. So I think the readout we currently have, the readout of liver function on biochemical analysis, so routine labs, I don't think this represents the true picture of the liver's functional state in these patients. And I would think that there are profound changes in several metabolic pathways, and it would be interesting to have a look at them.
All right, then in the interest of time, we move on, and we talked about how